Earlier we used to have this monthly academic meeting, and then suddenly, due to some reasons, we stopped this academic meetings and we started concentrating on postgraduate training programs. So I think like now the time has come for us to revisit our scientific academic activities. So from this month onwards, at least hopefully that on a monthly basis, we will be continuing with our monthly academic activities. So today we will be discussing a different, but I feel it's an important topic: the rise and fall of anthracycline. Take over the proceedings. Over to you, Ajju.
Yes, thank you. So the first slide is this: rise and fall of anthracyclines in early breast cancer. Now, special prize for somebody who can guess why this slide. What is connecting both? അടുത്ത slide. അല്ലല്ല ഇത് don't change.
Alex Ferguson.
Manchester United.
Manchester United.
Manchester United ആണെന്നില്ല എല്ലാവർക്കും അറിയാം. But why anthracycline in Manchester United?
Red color.
Red color എന്തോന്ന് പിന്നെ എന്തെങ്കിലും റെഡ് വെക്കാറുണ്ട്. കമ്മ്യൂണിസ്റ്റ് പാർട്ടിയുടെ ഫ്ലാഗ് വെക്കാറുണ്ട്.
After Alex Ferguson, everything Manchester was never.
Bad answer. Wrong answer.
Wrong answer.
Okay. ആരെങ്കിലും ഒരാളോട് അറ്റംപ്റ്റ് ചെയ്ത് ഞാൻ പറയാം. Okay, what is the nickname of anthracycline?
No idea.
Patients call it something actually. Our doctors anthracycline, patients actually refer to it by some other name.
Red devil.
Red devil, yes. So the logo, the motto of this thing, symbol of Manchester United is actually a red devil.
Right.
Anyway, next slide. So I am going to acknowledge this wonderful paper. If you want to read in detail of what I have been talking, I'll be talking shortly. Please refer to this. I can share this later if necessary. Next slide. And I want to dedicate this short talk to a few people. Now, this is why this is an important talk for me personally. Number one, my good friend A's mother. So I know her from my time abroad. She's a good friend, not a doctor, but her mother had breast cancer. And after a few years, she developed cardiomyopathy and she died quite young, 60 years old, from anthracycline-induced cardiomyopathy. The next one is P's mother. P is a young girl I know for a long time. In fact, I know the mother since I was born. I know her very well. She had a early stage breast cancer, and she was treated with chemotherapy, anthracycline. Now, when we look back, she may not have required chemotherapy that time, but she essentially got MDS, acute leukemia, and died. She went all the way to the US to get transplant, workup, and all those things. Nothing happened. She died. V's wife. Now, this wife is somebody I know for the last 12 years. I don't know him well. We just married his wife, which is my like a young sister to me. After a few days of marriage, she developed breast cancer. The surgeon excised the lump, didn't do a true cut biopsy, so there was no option to give neoadjuvant chemotherapy. Came back after the excision. It was like a T2 cancer, clinically node negative. Decided to give some neoadjuvant therapy before further excision. Gave anthracycline-based therapy, triple negative, high risk, Ki67 80%. After radiation, adjuvant radiation, 4 months later, she developed leukemia and died last week, 28 years old. The next is SA. SA is somebody with breast cancer that I have treated myself. Came with a lump in the breast, HER2 positive, hormone positive, gave trastuzumab-based therapy, 1 cycle, absolutely no response to the disease. Switched to doxorubicin-based therapy for 4 doses. And after that, did the surgery, no response on the disease. So again, no response to neoadjuvant chemotherapy. Then I gave docetaxel-based therapy. She couldn't afford too much trastuzumab. She just gave her 4 more doses of trastuzumab. About a year later, she's now with MDS. The last is CA. This is my patient from the US. I didn't treat her at that time. My professor who retired and I adopted his practice, he treated her. He recollects this story. She had a very small breast cancer. She came to him and said, he said, you don't need chemotherapy. She said, no, doctor, please give me chemotherapy. He basically gave her TAC. She developed leukemia and got marrow transplantation, is disease-free and living a good life, a normal life. So this talk is dedicated to all these real people who had real damage from anthracycline. Next slide. So Hippocrates says help or at least do no harm. So that is our fundamental thesis on which we will have this discussion. Next slide. Some history. Doxorubicin was approved in 1974. Now, I wanted to do a questionnaire. Let me just do it because I couldn't. This is not my updated slides. So I'm going to ask everybody some questions to think about. Please write down the answer somewhere so that you can measure it against your own, the final answer. Okay. So if you treat 1,000 women with breast cancer with an anthracycline based regimen, how many would eventually get therapy related MDS or acute leukemia? So if you treat 1,000 women with breast cancer with an anthracycline based therapy, how many would eventually get therapy related MDS or acute leukemia? The next question, I hope you have written a number, not 100 women, 1,000 women. Okay. The next question, if you treat 1,000 women with breast cancer with an anthracycline based regimen, how many would eventually get therapy related cardiac dysfunction? Therapy related cardiac dysfunction, 1,000 women. Hopefully you have written down the answer or made a note. The next question is, out of 100 young women with clinical prognostic stage 2 breast cancer, anatomic stage 1, anatomy wise stage 1, but based on current AJCC age, prognostic stage 2 breast cancer, triple negative, who achieved pathologic complete response to neoadjuvant chemotherapy. You didn't give, I'm not going to say what chemotherapy they got, but just going to say they got complete response with neoadjuvant chemotherapy. How many will eventually develop distant recurrence? So out of 100 women with stage 2 prognostic breast cancer, anatomic stage 1, who achieved pathologic complete response to neoadjuvant chemotherapy, how many will eventually develop distant recurrence out of 100 women? Last question. If a young woman with the same woman who had great response to neoadjuvant non-anthracycline based chemotherapy, would you still recommend anthracyclines as adjuvant therapy? Yes, no, maybe. 3 options. Yes, no, maybe. So that is, patient got great response to non-anthracycline based neoadjuvant chemotherapy and pathology complete response, and the patient has come to you. Now, would you give anthracycline as an adjuvant therapy? That's the question. Okay, now let's get back to our topic. So, history of doxorubicin, anthracycline, it was first approved in 1974. The first meta-analysis of pre-1996 trials of 14,000 women showed that when compared to CMF, there was a substantial survival benefit when you use anthracycline. When this meta-analysis is updated in 2012, there was no difference in recurrence or mortality. But keep in mind that this study, at that time, HER2 status was not known, so we can't comment with confidence. Next slide, please. And then started the era of taxanes, 1990s. Taxane, docetaxel was tested against doxorubicin in metastatic breast cancer, and they found that docetaxel is better. Next slide. So taxanes brought on a new era of therapy, and therefore Stephen Jones et al. Did their first important study, which is TC versus AC for 4 cycles. TC versus AC for 4 cycles. 1,000 patients, stage 1 to 3. 65% of patients were hormone positive, 50% node positive, 10% more than 3 nodes, 27% hormone receptor negative, HER2 status not known. Disease-free survival and overall survival favoring the taxane arm. But 3 MDS leukemia deaths in AC arm, 1 CHF death in AC arm, none in TC arm. So with this study, we again got more evidence suggesting that taxane head-to-head versus anthracycline, TC versus AC, for a non-HER2 selected population is better. So TC for 4 is better than AC for 4. Next slide. And then an alliance trial was done, which is a 2x2 factorial trial. In this study, they did an AC versus T. Keep in mind, there is no cyclophosphamide. There is just a paclitaxel, AC versus T. And because this is a 2x2 factorial design, they also got the freedom to test 4 versus 6 cycles of AC. Okay, I'm back on my computer. Okay, I'm back on my computer. Can you hear me?
Can hear you, Ajit.
Okay, come on. Okay.
Yeah.
Do you want me to control the screen?
Yeah.
Slides?
You control them.
Hashim, can you screen share or close?
Yes, sir. I'm closing. Sir, share ചെയ്തോളൂ.
Sorry, same trouble. Power cut. Kekamo. Yes. So alliance trial. Hashim, continue to screen share, please. So the next. So in this study, 3,800 patients. It was prematurely closed. No HER2 status was identified in the study. No cyclophosphamide given. Yet after 5 years, no difference between AC versus T. And in the AC arm, 7 deaths from MDS leukemia. So not trivial numbers. Next slide. Finally, we have studies in HER2 negative patients. So this is when we finally have isolated homogeneous patient, HER2 negative. 3 studies were tested. I'm going to not go too much into details of these studies, but just understand that these 3 trials followed by, these are all high risk node negative or lymph node positive patients. Finally, these were all combined in 2017, published as one analysis called the ABC trial. Next slide. The ABC trial had 4,000 patients. 30% of patients were TNBC. 59% were lymph node positive. 51% were high grade. The study was a non-inferiority design. They were trying to figure out if TC was non-inferior to AC. And the study found that TC was not non-inferior, which means anthracycline had some better outcomes, even then, even now. But for whom? When you do the subgroup analysis, they figured out that most of the benefit was in lymph node greater than 4 group. And that too, in that group, in the triple negative subtype, the absolute difference was 11%. For hormone receptor positive subtype, the absolute difference was 6%. And there were 5 AMLs in the anthracycline arm, none in taxane arm. So this study showed that anthracyclines had some benefit in HER2 negative patients, but mainly in high risk patients who were node positive, greater than 4 nodes positive, and triple negative, greater than 4 nodes positive. Next slide. A similar study was done by the West German group, West German Plan B study, comparing TC46 versus EC44 followed by docetaxel. Here they used a higher docetaxel dose, 100 milligrams meter square. High risk patients, triple negative 17%. The other study had 30% triple negative. But at the end of the day, disease-free survival is identical. And that is probably because there was less TNBC patients in this study. But broadly, this study concludes that anthracyclines are similar to non-anthracyclines. Next study. Next slide. Success C trial, 3,642 patients. FEC followed by 3, FEC for 3 followed by DOSI for 3 versus TC for 6. This study, they decided to pool the analysis with Plan B trial. Again, 22% of patients has TNBC, and the only people who had benefit from anthracycline were those who had greater than or equal to 4 lymph nodes. Next study, next trial. So now coming to anthracyclines in TNBC exclusively. In TNBC, in the ABC group, there was a positive signal favoring anthracycline in the triple negative group, not for the entire study, not for hormone receptor. So the ABC trial actually concludes that anthracyclines are beneficial in high-risk patients like triple negative breast cancer or node 4 nodes positive N2, N3 disease. This was most evident in node positive TNBC. There were 2 other interesting cohort studies from Kansas and Spain. High-risk patients, triple negative, 50% lymph node disease. And in that patient's population, all of them got neoadjuvant carbo-docetaxel for 6 cycles. Pathologic complete response rate was 55%. In patients who had pathologic complete response, 3-year recurrence-free survival was 90%. Overall survival was 94%. So patients actually did better even when they had pathology complete response. And the investigators in this study, only 5 out of 100 patients who got PCR, they decided to give adjuvant anthracycline. That is 95% of patients who got complete response for this TNBC cohort with pathology complete response, the investigators did not give anthracycline. And when you compare that with those who got, there's really no difference in anthracycline based outcomes. Next slide. So what about anthracyclines in HER2 positive era? In the trastuzumab era, pre-trastuzumab era, anthracyclines were found to be beneficial in HER2 positive disease. But in the post-trastuzumab era, what happened? The BCIRG 006 trial actually tested AC followed by T versus AC followed by TH versus TCH. And keep in mind that the C in TCH is carboplatin because they have found a synergistic effect with platin with trastuzumab. And at the end of the day, with a post hoc analysis, there was no difference between anthracycline versus non-anthracycline. But there were more AML and MDS in anthracycline arm. If I recall right, there were 5 AML MDS in anthracycline versus none in non-anthracycline arm. Next slide. The TRAIN-2 study then looked at a very similar design where they used FEC followed by HP. Now here's a study that looked at pertuzumab versus TCHP. Interestingly, despite using a 5-drug regimen versus 4-drug, PCR and EFS rates were identical, even in those greater than 4 nodes positive. So HER2 positive, even high-risk patients, no difference with addition of anthracycline. And in fact, more AML and MDS were noted in the anthracycline arm. Next slide. Finally, let me come to the large early breast cancer trialist group meta-analysis 2023. In this EBCTCG meta-analysis, which was published in 2023, just a few months ago, they brought together 15 trials, the individual participant data, 18,000 women. It was a very heterogeneous study design. Heterogeneous because there was some patients with hormone positive, some with HER2 positive. The timing of trials, some were neoadjuvant, some were adjuvant. The regimen used, some used AC weekly, AC 3 weekly, docetaxel. Some used different type of taxane. Schedule of administration, some used 2 weekly, some used 3 weekly. Some used it with FEC, some used just AC. Frequency was different. Cumulative doses were different. Treatment duration were different. Types of drugs used in the control arm were different. Some actually had capecitabine, some had carboplatin. So there was a lot of heterogeneity in study design. But what the meta-analysis found was, when you use concurrent anthracycline taxane, those patients did better than sequential anthracycline taxane. So for instance, TAC did better than AC followed by T. Higher doses did better than lower doses. And more dose intensity did better than less dose intensity. So let me repeat. Concurrent ACT did better than sequential. Higher doses did better than lower. More dose intensity did better than less. But the editorialist says that there is no reason to make any changes in the current guidelines, which is the current guidelines suggest we use less anthracycline. Current guidelines suggest that we don't use concurrent anthracycline taxane, TAC, we just use AC followed by T. So the editorialists say that because of the heterogeneity in the study design, we can't be sure that TAC is actually really better than sequential anthracycline taxane. But this meta-analysis suggested that more dose intensity, higher doses are better. So you may want to consider such a protocol for patients at really, really high risk. Next slide. So the EBCTCG meta-analysis was useful because it also gave us some information about AML risk after anthracycline. Here again, the problem was there was heterogeneity in study design. So some studies did not have good follow-up. Some studies did not have mortality data. Some studies did not have diagnosis data, but just mortality data. So this is likely to be an underestimate of the real incidence. But essentially what it showed was 1 in 700 given anthracycline were diagnosed with AML. 1 in 700. Next slide. So do no harm. What do we know based on multiple studies? Leukemia risk, MDS risk. How does that happen? Because of acquired somatic mutations in hematopoietic stem cells. Topoisomerase 2 inhibitors induce chromosomal breakages and translocations in regions known to cause malignant transformation. And the meta-analysis suggested 1 in 700, but other studies suggest a 0.2 to 1.7% cumulative long-term risk. My best estimate, which is a best case scenario, that is, I'm not talking about worst case scenario, but best case scenario based on my studies suggests that about out of every 1,000 patients we give anthracycline, around 2 to 5, or rather 0.2 to 0.5% get AML MDS. So if you answered it right, give yourself a pat on your back. So the answer to the first question, out of 1,000 women who get anthracyclines, how many would get AML MDS? The answer is anywhere between 2 to 5. I think that will be the best estimate. Not a worst case scenario, but the best case scenario. Keep in mind that the risk could be dose dependent. Dose dense maybe supposedly has slightly more risk than 3 weekly dose. Next slide. Next slide. Cardiac risk. Coming to the end of my talk, so not too many slides left. Hang in there. Cardiac risk. Long-term studies with systematic follow-up. So this is very important because we need long-term follow-up, regular echo monitoring. BCIRG 006 trial is one trial that did that, and they found that the symptomatic CHF rate is 1 to 2%. But LVEF decline of greater than 10% happens in 10 to 20% of patients, and this is irreversible. So my assessment of understanding this, the answer to the question, out of 1,000 women who get anthracycline, how many get therapy-related cardiac dysfunction that includes symptomatic disease and LVEF decline of greater than 10%? My best estimate is 10% or 5 to 10%. So if you have answered anywhere from 50 to 100, that is out of 1,000 women, if your answer stands between 50 and 100, I think you've got it right. So out of 1,000 women, 50 to 100 get therapy-related cardiac dysfunction. Next slide. So I did a survey a few months ago in preparation for this talk. I sent this across to AMPOK group. Some of you have responded. The same survey. I sent it to the ISMPO group. Some of you responded. I got 32 responses. Next slide. Next slide. The first question is about therapy-related MDS leukemia out of 1,000 women. Next slide. This is the response. Nearly 50% of the responders suggested 0.1 to 0.5%. That is around 2 to 5 out of 1,000. The rest were all over the place. Next slide. So correct answer is 50%. Got it right. Next slide. Therapy-related cardiac dysfunction out of 32 responses. Next slide. The right answer is anywhere from 6 to 10%. That is 50 to 100 out of 1,000. 6 to 10%. So only 12% of responders actually got it right. Next slide. Next slide. Out of 100 women with clinical prognostic stage 2 breast cancer who have achieved pathology complete response, how many will eventually develop distant recurrence? So these are all good prognostic patients who have achieved pathology complete response. Next slide. So keep in mind that this is stage 1 triple negative or prognostic stage 2. So they are already going to do well. Their survival without any adjuvant therapy is also very high. With good therapy and you get pathology complete response, the chance of them being disease free is very high. So how many will eventually develop distant recurrence? And it's all over the place. I can't imagine how somebody would say 20%, 50%, etc. Even 10 to 20%, I can't imagine. But next slide. So the correct answer in my best estimate is 2 to 5%. So this is early stage triple negative patients who got pathology complete response. How many will develop distant recurrence? Small proportion, 2 to 5%. Next slide. And how many would still recommend anthracyclines as an adjuvant therapy if you've given non-anthracycline therapy and you got pathology complete response? Next slide. 28%, 30% said they would still give anthracyclines. Overwhelmingly, I don't understand why most people said no, but actually most people got the other answers wrong, but still most people got the answer right for this one. That's at least comforting. And majority of people, responders, at least said that they will not give adjuvant anthracycline or at least discuss with the patient, maybe. So the right answer is no or maybe. Next slide. Next slide. So only one oncologist got it all right. So the yellows are people who got it right. The first column is those who got it right for the first question. The second column is those who got it right for the second question. Third column is those who got right for the third question. Fourth column is those who got it right for the fourth question. Surprisingly, a lot of people got a lot of right answers despite getting a lot of the answers wrong for the first, second, and third question. That gives us a lot of comfort. And next slide. So who do I advise anthracycline? This is up for debate. You can all discuss, debate, comment. If the patient is otherwise eligible for the drug, I advise anthracycline in patients with hormone positive HER2 negative N2, N3 disease. Triple negative breast cancer stage 1 and 2 as adjuvant therapy. That is, patient got surgery and then they are coming to me. I would give stage 2 definitely. Stage 1 maybe. I will have a discussion with patient. These are patients who did not get neoadjuvant therapy. But stage 3 prognostic, whether they come before surgery or after surgery, everybody gets anthracycline, in my opinion. HER2 positive, I would give neoadjuvant anthracycline and adjuvant anthracycline. I would consider it for stage 3 patients. But really, in some patients, post neoadjuvant stage 3, if they do really well, I can either omit anthracycline, as the studies have shown. Very little benefit to anthracycline. But for stage 1 and 2, post neoadjuvant non-anthracycline therapy, if there is substantial residual disease, I would give anthracycline. If there is microscopic disease, I would discuss with the patient. Next slide. Thank you. Comments, thoughts, suggestions. Go back one slide and keep it there so at least we can have a discussion over this. Thank you. Now the floor is open to questions, comments, rebuttals, extra thoughts, additional insights. Thank you.
Thank you, Aju. Thank you, Aju, for this taking up this topic, because I feel the reason why we had this discussion and we was that I feel like the time has come for us to start revisiting the usage of anthracycline in our day-to-day clinical practice. Anthracycline we use. We've been taught that, okay, for all node positive diseases, even if it is single node positivity, we have to start using this drug. We have to give anthracycline in the adjuvant setting. But considering the fact that once in a blue moon, you will get a patient who might develop an MDS or secondary. That's actually a very difficult scenario to handle. So that is the reason why I thought like of this topic, and I asked Aju to take it up. And thank you, Aju, for doing this extensive research on this topic and coming up with a very good presentation. So comments from others, and then I'll share my thoughts. You mentioned about this the second the risk of second malignancy. So I just want to ask, do the consent form which we use in our hospital, do they mention about the risk of second cancer? Which all hospitals mention the risk of second malignancy in the chemotherapy consent form?
Actually, that's an excellent question. I need to go back and look it up.
I
I
checked
don't
it up
think
today
my
because it is
consent
not
form
there.
has
It's
it.
not there in the
I don't think
consent
my
form.
consent. Excellent question. Excellent question. I don't think my consent form has it.
Because once we discuss about this option, so about curable malignancy like breast cancer, for that matter, anything, I think like we should be including this risk of second malignancy also should be there in the consent form. Otherwise, in the era of litigations, we might land up ourselves in trouble. I can worried, sir.
Yeah, I think the cardiac dysfunction is much more
Cardiac is
what
there.
we see. Yeah, cardiac dysfunction. And I don't know how many of you are doing routine echocardiogram in the review, because all the guidelines recommend mammogram and the pap smear and the maximum ultrasound once a year. And somehow we, in a very busy OP, we miss the echocardiogram. And unless you ask, I have lost about 5 or 6 patients in the last 25 years. And that too, it's a very big loss actually. The reason being, they are all treated 10 years or 15 years back, and then all sudden cardiac deaths. Like one lady who was getting ready to take the new delivery of a new vehicle, and the husband was just waiting for her. All of a sudden, she fell down and died. That sort of deaths, all cardiac deaths, and you can attribute to this cardiac dysfunction, which were not picked up by us. But they all never complained about any cardiac symptoms. So I don't know whether we are supposed to do echo at least once a year to pick up this 10 to 20% decline in cardiac function Aju was mentioning.
So but
What
the
is your
issue,
thought?
so the issue over there is like, see, who does the echocardiogram nowadays? No cardiologist is doing it. It's all purely done by technicians. So unless we ask them very specifically to what to look for, I don't think like they will be looking into this minor drops or anything like that. They will be routinely doing a screening echo kind of a thing, and then the patient will be sent back to us. Say at least in the hospital where I'm practicing, I know that it's done by technicians, not by cardiologists. Unless we specifically ask for a cardiologist, it's been done by technicians. I don't know what's the situation.
Everywhere it is like that only, Bob. And even in our hospital, there is an in-house cardiologist. But he's only part-time. But he doesn't do echocardiogram, and he reads whatever they have written, and very rarely he does. But I don't think that even if we send it specifically, they will pick up any anthracycline related toxicity, because because he is not oriented towards our oncology related problems, because his main practice is the general cardiology. Though he is oriented towards, he's aware of all the cardiac problems of our drugs, as well as the toxicities and whatever the issues. But I don't think that unless you as you said, you specifically look for it and you will not get it.
Another problem is most of these patients are diabetic, diabetic and hypertensive, isn't it?
Yes, Ajivan?
So, yeah, most of these patients are also diabetic. Even our young diabetes is also very common. So they are all chronically diabetic and uncontrolled diabetes, hypertension. So there is all the more reason to have a follow-up with echo, with a dedicated echo. The problem is that our oncology patients will not go to any other transplant. That's the problem. Even if they are so much uncontrolled hypertension, you are forced to treat them with whatever fetal knowledge you have with the anti-diabetic drugs. So they are very reluctant to go and consult others. That's a common scenario. Yeah.
Can I ask a question, Dr. Sridhar here?
Yes, sir.
No, this is to Dr. Aju, I didn't really understand your slide about adjuvant therapy post neoadjuvant residual disease. What is this condition? Because for stage 3 disease, we give neoadjuvant and then only we take up for surgery. So where is the question of adjuvant coming after that?
So patient is
I also
getting
wanted to ask that.
Same question.
Maybe it is confusing. So let's say patient is getting you're asking about the previous slide.
Yes.
HER2 positive.
Stage 1 and 2 post neoadjuvant any residual, because post neoadjuvant we finish the neoadjuvant and then take up for surgery. We never do surgery in between.
Okay. So post neoadjuvant, for example, HER2 positive, we give TCH for stage 2 disease, example, and patient undergoes surgery, and after the surgery, there is
anthracycline.
So in exceptional cases, you can give anthracycline post neoadjuvant. There are some study. I think there is a prospective study that have given it. So because if there is substantial residual disease,
are you going to salvage with your anthracycline? No way.
That is not totally happening in practice, isn't it?
I think Sridharan is asking because
connection boy. Hello.
Surgery
Well, what
will be
of
done only
chemotherapy
after
we are
completing the
giving is
neoadjuvant
actually
chemotherapy. The
a
neoadjuvant
sort of-
chemotherapy is 6 cycles. No, six. They once they complete all the chemotherapy as neoadjuvant, and then only they will go for surgery. So after the surgery, where is the role for any chemotherapy? That is what Sridharan is asking.
It's exactly the same way ECOG trial was conducted for carboplatin versus capecitabine. So the ECOG trial, which was presented, I think 4 or 5 years ago, that looked at patients who got chemotherapy, then surgery, then consolidating with a different regimen.
No, but for HER2 positive patients having residue, we look at trying to target the HER2. We don't try to give them more.
But targeting the HER2 is not affordable for most patients, no, sir. Like for instance, how many can get Kadcyla or Ujjwala? That is the best option.
We don't know how many will be giving anthracyclines at that time. Okay, I accept your point.
I also agree with Dr. Sridharan. We in practice we don't give sort of adjuvant. We give something like a total neoadjuvant. If you're planning a neoadjuvant, you are giving the entire set of chemotherapy upfront, and whatever residual is there, you are not actually targeting giving further chemo.
So stage 1 and 2 patients, you would give, for example, HER2 positive, you would give TCH, and patient undergoes surgery, and after surgery, pathology-wise, patient remains YPT2N1. Would you just continue with trastuzumab? I mean, patient can't afford Kadcyla, which is the ideal situation.
Yeah, continue with the trastuzumab. Such scenarios, we don't use adjuvant chemotherapy generally. That's what my understanding in practice.
Yeah, I mean, I try to, especially if there is significant residual disease, assuming that the neoadjuvant chemotherapy was probably not responding at all, I try to consolidate in patients who can't afford Kadcyla or Ujjwala with anthracycline.
So can you tell me any instance in oncology where tailoring of treatment based on pathological response is really proven to improve survival? It has not.
Create X trial. Create X trial.
3?
Create X trial. Capecitabine. Adjuvant capecitabine.
That is adjuvant capecitabine. But I'm talking about parenteral chemotherapy, starting with osteosarcoma. Anything you do, tailoring of treatment is never.
I mean, if so, extrapolating that to ECOG trial, where the control arm was capecitabine and the study arm was carboplatin, the study actually showed identical result. So if adjuvant therapy with capecitabine actually improved survival, then one can assume that carboplatin or IV parenteral chemotherapy would also improve survival.
So, such cases, you are unnecessarily delaying the delivery of anti-HER2 therapy, at least the trastuzumab, isn't it? because you are anyway
But,
not going to give concurrently.
But then the original 6 cycles of trastuzumab did not actually impact much.
But
Otherwise,
do
it
we
would
have
not be
any
significant residual disease.
recommendation like that?
I don't think there are guidelines suggesting consolidating with anthracycline, but this is something, this is where I advise, especially if they can't afford Kadcyla, at least they make the decision themselves. If they can't afford it, Kadcyla, there is no point continuing trastuzumab. I mean, there is some point, but not real great benefit with continuing adjuvant trastuzumab in patients who have not responded at all to neoadjuvant trastuzumab based chemotherapy. And most of our patients can't afford pertuzumab or Kadcyla. So let's say a young woman comes to your practice and you want to offer them the best chance for cure, and they understand the various issues, then I do offer anthracycline post surgery.
Aju, can I just ask one thing?
Mhm.
We have a locally advanced case of stage 3 breast cancer. HER2 positive,
Yeah.
started our own TCH regimen, and if the patient is not responding, in those group of patients, can we consider? I give anthracycline because I feel the best bet is for trastuzumab based combination, and there are sizable there is at least a good number of patients who have not responded to paclitaxel, trastuzumab, or carboplatin combination. So there is no, we are given neoadjuvant therapy and the patient is not working. Then there is no.
What? See, do you expect a PCR with your TCH or something?
There is
In all patients.
cases there is
In
no
all patients,
response to
isn't
that
it?
thing.
You don't expect now. Then why this thing at all? Why this consideration at all? Anyway, we know that we will not get 100% PCR. Whatever you use.
The substantial disease is left behind. If substantial disease is left behind, that is poor prognostic feature. So in patients with poor prognostic feature, studies have shown that intensifying the regimen with anti-HER2 therapy like Kadcyla, Ujvira has helped. And studies have shown that intensifying the regimen based on CreateX trial, the ECOG study comparing carboplatin and capecitabine have shown that intensifying the regimen post-operatively has also improved survival. So extrapolating that to our setup of patients where we cannot offer option. Isn't that what Bob and you were also suggesting?
Yeah. Same thing, clinically, the mass has not responded. I'm not speaking about a complete pathological response. Clinically itself, we can feel the lump is even after 2 or 3 cycles, the lump is not that it has not responded. In those group of patients, can we try an anthracycline?
Switch therapy to anthracycline. That is okay. That is absolutely fine.
That
I
is
think.
fine. As
But
neoadjuvant,
sir,
That's all
Yeah,
again.
neoadjuvant.
yeah.
Any other comments? So just like for single node disease, like we are in the era of nowadays they are doing a sentinel node, so they just will be removing only one node or something like that. In those group of patients, you feel that there is no need to give anthracyclines?
So all these studies have shown that the greatest benefit for the anthracycline in hormone positive is in N2 disease, N3 disease.
Yeah.
And in HER2 disease, actually not many benefit much because of the advancements that we have currently with trastuzumab based therapy. With triple negative, again, most studies suggest that high risk triple negatives, higher stage benefit. So for hormone positive, luminal subtype kind of node positive, I aim to give TC for 6 cycles.
Only TC, no. All this N2, N3 are all pathological N2, N3, right? They are not
Correct.
Pathological N2, N3.
Those were all adjuvant trials. I mean, my point is if we reduce the numbers of anthracycline we use cumulatively as a group, obviously we'll actually save some women, do no harm kind of thing. So reducing based on actual evidence, the indication for anthracycline is now getting smaller and smaller.
Okay, good. Okay, we have it's almost 9 o'clock. Thank you, Aju. Thank you, Sajivan sir.
Thank you. Thank you.
Varied sir, Sridhan sir, everybody for that inputs.
Yeah, it was a good discussion, Bhavan. It was a very good discussion.
An
Yeah.
important thing which I feel like we should have this interactive discussions rather than having a typical presentation. So I'm trying like henceforth all this practice, changing your practice. What are things are important in your day-to-day clinical practice? We'll try to have more discussions in our AMPOK groups. Closed, small discussion, but it will benefit all of us. Thank you, Aju, and all others for participating. Good night.
Thank you. Good night.